Mm. Good morning. I online. I here.
Yes, good morning.
Good morning. I have been waiting for you. Tell me, please, how are you these days?
I'm fine, thank you. And you?
Fine, thank you. What about the rest of students? Do you have any information about them? Where are they? Are they coming or not?
I think some students will be joining now.
Mm-hmm. Okay, so if you don't mind, let me start, and then we'll. Anyway, I'm make a record of this lecture, and it will be available for you. Okay.
Okay.
Okay. Do we have some preceding, some preliminary questions in the topics? Today we have
No, for now, no.
today we have gastritis and peptic ulcer disease topics. Have you already studied them in the practical classes?
No, we haven't.
Okay. So I hope it will be useful for you. Don't forget to register in the feedback form. Let me check. Any have registered? Yeah, thank you. You have already. And we have some more students came. Hello. Oh, hello, Basma Youssef. Did you solve your problem with the registration to the lecture, some of our lectures?
I don't know. Nobody talked to me.
Pardon?
Nobody talked to me after I talked to you.
Oh, really? Because I've sent the request, so let me check. Here is our communication, your proof. Okay, okay, I'll ask her again. Oh, bože. We have alert now of bombing. Okay, so let me ask. Uh, and I'll ask whether they have solved your question. Because frankly, I'm not connected to this at all. Uh, there are other people, other colleagues. Uh, there was some other lecturer that time, probably. Okay, I wrote a request, a reminding for my colleague to check your situation and help as much as
Okay,
possible.
thank
Okay, so let's continue. Hello for those who are coming. Good. Let's return to our topic. Today we have two topics to discuss, one in gastritis and one more in peptic ulcer disease. I have already got that you haven't studied this in the practical classes, so it might be useful for you. For instance, did you get the I don't remember. I've sent you some recommendations what textbooks to use in internal medicine. Have you received these references?
Uh,
I sent you. Let me find. Welcome to the lecture. I've sent you the links to Harrison's Principles of Internal Medicine and so on, to some fundamental textbooks. What textbooks do you use in your studies?
From the model, the lectures.
Ah, you mean some conspects?
Yes, yes.
I see. Look here. On the screen, I just show you. Here is the useful textbook. I've sent you previously. Should I repeat it to you?
Yes, please.
Because Harrison's Principle of Internal Medicine, it's the one of the most modern. Let me send it to you. And your email, right? Copy email. Okay, and useful texts for your studies, Harrison's Principles of Internal Medicine. It's just concise and it corresponds to different topics. I've sent it to different topics of internal medicine. Good. So let's return to gastritis again. Again, today we have two topics. First is gastritis. Gastritis, by definition, here is the authors of this presentation, my colleagues. It's inflammation of inner part, inner layer of the mucous membrane of the stomach. While in some cases, this inflammation may occupy even other parts, other layers of the stomach wall, and even may predispose to development of erosion, ulcer, and perforation and penetration to other organs as well as complications. So do not limit your understanding of gastritis as just a long-standing local inflammation. It may also occupy lower layers. We distinguish two conditions, acute gastritis and chronic gastritis. The difference is in duration, in the term, in the duration of these inflammations. And of course, we have exacerbation of chronic gastritis, which is very likely as acute, but develops on the background of preceding chronic inflammatory condition. So let's focus now on acute gastritis. First, by definition, it's acute affection of protective mucosal barrier, and normally, typically, or it's named naturally, the healing um, happens in few days. By a few days, we understand from 1 day to maybe 7 or 10 days. It depends on the severity of this inflammation and depends also on the measures we use to treat, to compensate this condition. While in chronic gastritis, we have a part of inflammatory changes. We have such significant components as remodeling of the mucous membrane, a change of the cellular presentation there, the types of cells present, and the dysregulation of the function of stomach, degeneration of mucous membrane, and acute gastritis is more typical for younger persons, and while chronic is a feature of elder ones. We distinguish several types of chronic gastritis. Type A, fundal, located in the fundus mostly, and type B, located in antral mostly. While they also have peculiarities not only corresponding to location but also um, to the nature of them, mostly related to autoimmune, to infection, and so on. The signs, symptoms, and complications of chronic gastritis and gastritis in general are following. First, clinical symptoms. Pardon. Um, just one moment. Before we continue with signs and symptoms, let me focus on maybe the incidence of gastritis. The first, in the terms of incidence, the important thing is what is the etiology. There are two main, maybe even three main approaches, three main groups of causes of gastritis. One of important is Helicobacter pylori or bacterial. Of course, because a part of Helicobacter pylori, there could be other infections causing gastritis, while in the majority of cases, more than 99%, it's Helicobacter. A part of these, they could be also food, drugs and chemicals influencing on the mucous membrane. And one more is stress related. It's not stated here, while we will discuss it more thoroughly on the topic of ulcer disease. In the gastritis, stress is usually rather often stated as a precipitating or risk factor, as some additional, not causal. Then alcohol abuse. Uh, as soon as alcohol influences directly by damaging of mucous membrane and indirectly by dysregulation of nervous supply and dysregulation of endocrine regulation as well. It also precipitates the development of gastritis. Smoking causes also multiple affection, both focal, it's not so important, but much more important is affection of, again, endocrine, nervous regulation, circulation, and so on, with inclination to inflammatory response of mucous membrane. Also, social habits. By social habits, we understand that irregular nutrition, for example, 1 or 2 times a day, maybe unreasonable eating, or maybe and so on. Some habitual aspects of development of these diseases also important. A part of these, they could be also caffeine or carbonated substances, influencing both locally by irritation of mucous membrane and indirectly by influence on circulation, blood circulation in the mucous membrane, with inclination to vasospasm, decrease of circulation, and by this decrease of defense of mucous membrane against normal, natural, aggressive content of stomach. Then use of anti-inflammatory drugs, non-steroid anti-inflammatory drugs, for example, also predisposes to development of inflammation, right? Not inflammation, but in this case, damage of mucous membrane, and therefore, even under the influence of anti-inflammatory drug, they could be indirectly delayed the development of inflammation after use of these drugs, after stoppage of their use. The incidence rate varies in different regions, but in general, in average, it's about 6.3 per 100,000 of population with acute gastritis. About 30 to 35% of adults have chronic gastritis caused by Helicobacter pylori. About 50% of people are over age 60, 20% under 40 years old. The more common this disease in developing countries because of well, maybe socially conditioned, inaccurate or unreasonable attitude eating, and maybe because of low income and some lack of possibility to have appropriate regimen, have appropriate food even sometimes. Gastritis is more common in men than in women. And here is this distribution by sex, by gender, that much more significantly more prevalent it is in males, and more typically it's related to not Helicobacter pylori associated variants of the disease. For instance, these presentations are available for you. I have sent you a link to all of materials I have prepared or used for today's meeting. Good. So, main signs, clinical signs related to gastritis include some change of appetite. It could be total loss of appetite, or it could be vice versa in case of ulcerous or erosive gastritis. It could be often hunger in these people because of irritation of mucous membrane. They are on this when they starve, they have this feeling, they have this discomfort or even pains, and after taking meal, they feel relief, so they are motivated to eat. They may not have appetite literally, but they trend to eat because they feel relief after taking a meal. Then coffee ground emesis. Yeah, it could be in case of uh, erosive again and bleeding, especially from the mucous membrane of stomach. Then indigestion. It happens mostly in hypoacidic conditions. So we distinguish normal acidic, hyperacidic, increased acidity of in stomach, and hypoacidic. And indigestion is more typical for hypoacidic. Abdominal discomfort is conditioned by irritation of mucous membrane by aggressive content of stomach. Epigastric tenderness or pain, same mechanism, is just more significant. Nausea and vomiting. There are different mechanisms of these symptoms, while main is again irritation of mucous membrane and hyperirritation of nutrition regulation centers in the central nervous system, and therefore one more mechanism of this is that these people with acute or exacerbation of chronic gastritis feel relief after vomiting because of elimination of this aggressive content from stomach and decrease of pain or tenderness or discomfort and so on. So this symptom is a presentation of protective mechanism in some sense. And black stools is a feature of this condition in case of bleeding, of course, from the mucous membrane. Complications which may develop in patients with gastritis include ulceration, so erosions, ulcers, stomach bleedings, development of tumors, and maybe in case of acute gastritis, it may get transformed into chronic. It's also complication of acute gastritis with chronic or transformation of it. These are main complications. The clinical symptoms by which we may suppose that there is some transformation of basic gastritis into something else, some complication, are for example, in case of transformation into ulcer, it's more often and significant pains than hunger pains in such a condition. Then, of course, it could be complicated ulcers and development of peritonitis even, but it's the indirect complication. The stomach bleeding is manifested um, by black color of stool mainly. The rest is non-specific. It could be also anemic condition in these people, such paleness of skin and visible mucous membranes and appropriate laboratory changes with decrease of red blood cells and hemoglobin and so on. The stomach cancer may be asymptomatic at all, while if there is a development of tumor, especially in pyloric or antral parts of the stomach, there could be also disturbance of evacuation of food from the humus from the stomach, and by this we may suppose and then continue with instrumental and laboratory tests, investigations to suppose on oncological pathology. So on the basic level of diagnosis, we ground it by acute pain, by imbalanced nutrition in the anamnesis. Then other aspects is risk for fluid volume deficit and so on. So, and for instance, in terms of, let me see, early detection, here it is. We should be aware about the already mentioned signs and symptoms and possible complications we already discussed with you. We have to educate the patient in terms of elimination of risks, for example, smoking cessation, eliminate alcohol ingestion, reduce stress as much as possible, and stop or limitation of using non-steroid anti-inflammatory drugs. At least even if we use them to use in parenteral form, but even in this case, they influence on the organism systemically, and they may still cause the development of blockage of protective mechanisms of mucous membrane. Therefore, we have to use some other approaches to treatment if needed, because non-steroid anti-inflammatory drugs are widely used in relation to other conditions such as hyperthermia or fever, such as autoimmune diseases, rheumatic diseases we have already discussed with you last time. A very important approach is nutrition education with normal meal sizes, with recommended or non-recommended foods, with avoid acidic foods, with best cooking methods. And in this relation, the maybe etalon or some typical food chart for gastritis includes in case if we have gastritis with high acidity, normal or high acidity, the contraindicated are irregular meals, large or small portions. Not recommended are sodas, coffee, alcohol, marinated, spicy, salty, smoked food, and mayo chips. So such food which has either extractive substances and irritates the mucous membrane directly or indirectly by influencing on the nervous or regulation or circulation in mucous membrane and so on. And we are mostly inclined in our recommendations to braise, bake, boiled, steam cooked meals, uh, using some eggs, cottage cheese, yogurt, spaghetti, honey, caramel, marmalade, and so on, or lean meats and fish, seafood, sausage, sweet fruits, sunflower seeds, coffee milk with milk or weak tea, mm, just pure milk, and vegetables, well-cooked vegetables. Okay, in terms of okay, okay, um, for in terms of diagnosis. In order to diagnose the presence and intensity of distribution of Helicobacter pylori, we conduct the blood tests for antibodies to it, put to this infection and to other markers of Helicobacter pylori, so-called breath tests, stool sample with culture tests, and optionally we may even perform biopsy and identification of Helicobacter pylori colonies on the mucous membrane. The mucosal changed in on the background of gastritis may be easily identified by endoscopy. Here it is the illustration of this. So using endoscope with visualization of mucous membrane may help us greatly to verify whether it is inflammation of mucous membrane or maybe not only in complication with erosions, ulcers, tumors, and so on. Okay, and a few words about treatments. For Helicobacter pylori, we use appropriate antibiotics. If this inflammation, development of gastritis with increased acidity takes place, we use antacids, histamine blockers, proton pump inhibitors in combinations or solely. And finally, these are the main aspects we have for gastritis at the moment. Here are the references. For instance, you have this link to this presentation in my email I sent to you. One more thing, just one moment. I'll show you. One moment. I'll remind you the oral changes this condition as well. Here are they. In acute gastritis, typically you might observe in the patient such a swallowed tongue or implicated. It may be also covered with after with ulcers or erosions. In case of normal or hyperacidic form, it may be even farried, hypertrophic, and in case of atrophic gastritis or hypoacidic gastritis, you might observe a dystrophy or atrophy of papillae of mucous membrane uh, of in oral cavity as well. So they are closely related to each other. Okay, so okay, good. So let's make a short break now. And please check whether you have registered. You have registered. Okay. What questions do you have in gastritis? Maybe dental issues of gastritis. Anything like that?
No, nothing.
Mm-hmm. I must say that in acute form of gastritis, they could be. I forgot to make a screenshot for instance. They could be also reflux and therefore there could be damage of teeth with these acidic contents, and finally this predisposes to development of degenerative changes of teeth, especially caries and inflammatory changes like gingivitis and stomatitis, and this indirectly may also predispose to further development of parodontitis and even parodontosis finally. So this is a good example when management of the internal disease, gastritis, might significantly help to conduct proper treatment of dental ones as well. So let's make a short break now. I beg your pardon, dear students. So, the second part of our lecture is dedicated to peptic ulcer. Yeah. Okay, back. Good. So this is a presentation of my colleague from partner university, and let's go. So, if in brief, uh, by peptic ulcers, we understand the different damages of mucous membrane of mostly organs of gastrointestinal tract, and most often they happen in the stomach or duodenum. Here are two locations. In this place, um, normally, naturally, there are significant changes of acidity from acidic content of stomach into um, mostly vice versa condition and duodenum. And in this relation, if the normal passage of food is altered, there are conditions in which inflammatory changes appear, gastritis or duodenitis, on the background of which there is a risk of erosions formation and even ulcers. I remind you the difference between erosion and ulcer is in the so that in erosion there is no damage of basal membrane, while in ulcer there is. Um, Due to the imbalance of protective factors and aggressive factors of in relation to the mucous membrane, they could be damage of mucous membrane and therefore development of defect. Historically, one of the first reports about the role of Helicobacter pylori um, were made by Robin Warren and Barry Marshall in 1982. They discovered the association of Helicobacter pylori infection with gastritis and peptic ulcers. At that time, there was an approach that Helicobacter pylori is a normal bacteria which is a saprophyte and may be present in the gastrointestinal tract, and nobody believed. Just one moment, I beg your pardon. Just a few seconds. Pardon. Okay, so anatomically, the role of the mechanism of development of ulcer and preceding inflammation corresponds to disproportion of aggressive influence and protective factors which are present here. For example, prostaglandins uh, and circulation and production of mucus, they and so on, they play protective role and defend the mucous membrane against the aggressive contents of stomach. Vice versa, hypochloric acid and aggressive components of food and infection and probably sometimes mechanical influence or chemical or temperature and so on, they alter, they influence on the mucous membrane, damage it, and this is an usually it's normal, it's natural mm, balance between these two groups of factors. And normally, uh, the protective component is enough powerful to compensate the aggressive influence of outer factors. What happens in case of gastritis or in our case of peptic ulcer? By some reasons, there is either depression of protective mechanisms or more powerful influence of aggressive ones. The main symptoms of ulcer may be described as pain in the epigastric region, sometimes with irradiation. It's usually sharp. It trends to development starve condition, and it has burning tinge. Then the feeling of fullness, or bloating, or belching might be also present in this condition. The fatty food intolerance develops as a result of dysregulation of digestion in these patients. The heartburn symptom, it's a feeling of such a discomfort or thank you, or even burning pain above the chest, and it's a result of reflux of stomach contents into esophagus. And nausea. Nausea is a result of irritative influence on the mucous membrane and lower layers of the walls of stomach or duodenum or so. Then, a part of this, they could be vomiting and even vomiting with blood. These contents might have red or black tinge. It's because of damage of the mucous membrane and vessels and bleeding development. And it's a more specific symptom of erosion, or in this case of ulcer, than previous mentioned. Then there could be dark discoloration of stool. Uh, it is even similar to coffee grounds by the color. Then there could be problems with breathing, like limitation, discomfort, especially in inspiration phase. Feeling faint, nausea with vomiting, and then unexplained weight loss may be also present, and appetite changes. The causes of, as we have mentioned with you, of ulcer is in disproportion between invasive factors and defensive factors. The invasive are mostly hypochloric acid, non-steroid anti-inflammatory drugs, smoking, Helicobacter pylori, and protective are mucus and gastric cells, bicarbonate synthesis, and by this compensation of chemical damage with hypochloric acid, and of course blood flow, appropriate blood flow. The pathogenesis of hypochloric acid influence non-steroid anti-inflammatory drugs and Helicobacter pylori is in elevation of secretion and influence of hypochloric acid, and this leads to damage of the mucous membrane, more significant, and therefore uh, the non-steroid anti-inflammatory drugs by blockage of protective mechanisms, such non-steroid drugs as celecoxib, diflocofenac, or diflunisal, or etodolac, and others, ibuprofen, and indomethacin, ketoprofen, they lead to blockage of prostaglandins, and therefore this leads to uh, to problems with relief of pain, fever, and inflammation. And as soon as these non-steroid anti-inflammatory drugs inhibit cyclooxygenase, there is less prostaglandin production, less production of protective mucus, and less clotting, and the development or predisposition at least to erosions, ulcers, and finally bleedings. Um, and okay. A few words about Helicobacter pylori. Previously, we have stated that about 30 or so percent of gastritis are caused by or associated at least with Helicobacter pylori. And as for predisposition factor of ulcer, it also plays a great role. More than half of all people are carriers. They have this infection in their stomach, and it has some variants of Helicobacter pylori. Stains of them are more likely to cause development of ulcer, some other less. But in general, we are aware about the role of this bacteria in development of both gastritis and ulcer. The risk factors of ulcer disease is again use of non-steroid anti-inflammatory drugs, advanced age. With age, the probability of development of ulcer is increasing. Then family history of ulcers previously, untreated stress, if some person doesn't care about this and turns into distress regularly, this leads to also disturbance, stressogenic disturbance of protective uh, measures, protective factors, and predisposes to ulcer. Then use of eating of spicy food, alcohol consumption, smoking, and so on. The diagnosis of ulcer is related to physical symptoms and obligatory proving by instrumental investigations such as endoscopy or X-ray or laboratory tests and so on. The medical history helped to suppose that there is predisposition, some congenitive predisposition to ulcer, and especially we take care about whether these people have been using non-steroid anti-inflammatory drugs and associated with development of ulcer. The laboratory tests help to prove that there is in development of excess development of Helicobacter pylori. There are simple express tests with breathing or from blood or stool tests for this. Of course, the main method of diagnosis is endoscopic. By endoscopy, we may locate the defect of mucous membrane, evaluate its peculiarities, and even make a biopsy in order to further uh, more specifically identify what actually happens in this location. Here is the outlook of typical endoscope and the procedure. A part of this, in some cases, it's reasonable, not always, but in some cases, it's reasonable to perform the X-ray investigation, including computer tomography. This may help us to exclude some other conditions which simulate symptoms of ulcer and or specify whether there are complications or some other states associated with peptic ulcer. Formally, we may distinguish two types of peptic ulcer, such as acute and chronic. In acute, there are usually multiple small mucosal erosions, mostly in stomach, sometimes in duodenum. They may be caused by or conditions precipitated by psychological factors like overstressing or some severe trauma or septicemia or extensive burns or drug intake or local irritants and so on. As for chronic peptic ulcer, there is mostly following sites as stomach, duodenum affection, or maybe the margins of gastroionostomy. The differences between chronic gastric ulcer and chronic duodenal ulcer are in the following. First, in the constitution, in chronic gastric ulcer, people are mostly thin and anemic. While duodenal ulcer may develop in almost healthy males. In both of these types of ulcer, males dominate, but more often gastric one. The periodicity is less marked in gastric ulcer, while much more developed in duodenal. By periodicity, we understand inclination to development of exacerbation on spring and at spring and autumn periods. Pain in gastric ulcer is boring or pricking in nature, while in duodenal ulcer it's more severe and spasmodic by its nature. The site of location of pain in gastric is mostly epigastrium, and duodenal ulcer mostly on transpyloric plane. Then relation with food. Gastric ulcer, pain not felt, empty stomach, food aggravates pain, while in duodenal felt in empty stomach and good relieves and food relieves pain. Vomiting. In gastric ulcer, it's noticeable in half cases, while in duodenal ulcer, it's much more rare. The diet, uh, patients avoid fried and spicy food in gastric ulcer, while there are no initiatives from patients if there is duodenal ulcer. The hemorrhage is less common in gastric ulcer, but more common in duodenal. And on physical examination, the tenderness is slightly felt on gastric ulcer, and tenderness is situated on transpyloric with spleen 1 inch to midline in duodenal ulcer. So it's rather soon we have to finish with you with the lecture. Do you have any specific questions at the moment regarding gastritis or ulcer, peptic ulcer? Your colleague, dear students.
No questions.
Hmm? So again, let me remind that I have sent you, let me show, sent. I have sent you all the links with the, here is the presentation. So you may follow this link, and here are both presentations and links to other presentations are located. So you may easily use them. Okay. So thank you for coming. See you. Good luck.
Thank you, Doctor.